in Salt Lake. So we're going to say the barometric pressure is 640 millimeters of mercury. What do we have to do to any air we breathe into our lungs?
Add water
We have to add
vapor.
water vapor to it. And at 37 degrees, Kyle, how much is that?
47.
47 millimeters of mercury. 640 minus 47 is 593. And that the FiO2 on this device, let's say, is 80%, 0.8. 80% of the environment with a non-rebreather is being inhaled into our lungs. We're going to breathe normally minus the PaCO2 of 40 times 1.25. 40 times 1.25 is 50. 593 times 0.8, what is it?
474.
474 minus 50
424.
equals 424. So this amount of oxygen, millimeters of mercury, we're measuring, alveolar gas equation measures the partial pressure of oxygen in our alveoli. So that means instead of what's normal at sea level, 80 to 100. 80 to 100 is normal at sea level. If we breathe a non-rebreather at this elevation, and we understand it to be 80% oxygen, the partial pressure of oxygen in every alveoli is 424 millimeters of mercury. A PO2 of 424. So it goes across 9 layers of tissue, and in the arterial blood, we end up with 424 millimeters of mercury. Wow. Holy shnikey. So what we do as practitioners is we manipulate the alveolar environment by giving an oxygen cannula or a non-rebreather or alter the FiO2. We're really manipulating the alveolar environment. Make sense?
Yeah, it does.
So what's the saturation with a PO2 of 424? 100. It's absolutely 100.
424.
So PO2 of 80 to 100 yields a saturation of 96 or 97%. So anything over 100 is gravy, man. Right? A PO2 of 300 or 400 or 500 or 700, that's just gravy as far as saturation is concerned. Okay? So is oxygen a good thing? We'll talk about that in the advanced level here.
Would that be over time if you're at that high of a PaO2?
Yeah. So in the alveoli, what's a consequence of oxygen? What are some of the side effects, or what are the downsides, complications if we give too much oxygen? Now, if I'm giving 100% oxygen, and here in the how much nitrogen is in there? 78%. But if I'm giving 100% of the environment of oxygen, yes, all of the oxygen goes into there. There's no pressure to keep these things open. So what happens?
Wow.
Micro atelectasis and nitrogen washouts. And so what happens to these things? It collapses. So there are consequences to getting too much. Microatelectasis, nitrogen washout. In newborn infants, retinopathy of prematurity. Another name for that is retrolental fibroplasia. So it causes retinopathy, and it can cause blindness. So, but the thing with infants and oxygen is, I mean, sometimes you'll be in the newborn ICU, and a new mom will come up to you and say, "My baby's on 100% oxygen. Can't that cause blindness? I've read that it causes blindness." And it's not the FiO2 that causes retinopathy; it's the PaO2. So if they're on 100% and their alveoli are collapsed and their PO2 is only 80, that's not the problem. The problem is when we give too high of oxygen concentration, a high FiO2, that causes a high PaO2. So the PaO2 causes retinopathy, not the FiO2. We're using the FiO2 to treat therapeutically pulmonary diseases. And in newborn infants, the pulmonary disease is usually a lack of surfactant and broad spectrum atelectasis and collapse.
So if the PaO2 gets to 100, is that when that
That's,
happens?
yeah, 80 to 100 is normal for sea level. So if it's over 100, they've got too much.
Even in adults, because that happens a lot.
Even in adults, a PO2 of over 100 is too much. And particularly at this elevation. Because normal for us at this elevation is 70, 72, we calculated it. So if their PO2 is 100, that's too much for this elevation. And there are complications to too much oxygen. There are, I'll just say this and then we'll talk about it and investigate it a little further. But oxygen causes free radicals in the human body. And free radicals destroy DNA, and it's probably associated with the aging process. So DNA changes because of oxygen-free radicals scrubbing the proteins in DNA, and it causes problems. It causes cellular death. It causes recombination of proteins in the DNA, and it's not a good thing. So oxygen is a drug. It is a gas, and there are complications, and we have to judiciously manipulate the FiO2 so that the PO2s are 80 to 100, or for us at this elevation, 72. Right? Or if you're at Everest, it's okay if it's 30, as long as you take a little 2 or 3 liters. Now let's do that. Let's manipulate a patient with 2 or 3 liters of oxygen. So in a way, I'm belaboring the point, and I'm trying to give you examples of how we manipulate the alveolar environment through the alveolar gas equation. And besides that, it'll probably be longer. So if the barometric pressure is 640 millimeters of mercury right here, right now, if we inhale that gas, so this is barometric pressure, minus water vapor, we inhale at 37 degrees, it always exerts a partial pressure of 47 millimeters of mercury, and that holds physically 44 milligrams of water. Times, what's a cannula at 2 liters a minute? What's the FiO2? 28%. 0.28, 4% per liter, right? So on a cannula at this elevation, I'm breathing roughly 28%. Minus the CO2 of 40 times 1.25. 40 times 1.25 is 50. 640 minus 47.5, 93 times 0.28.
What is it as far as what is it represented?
Times
It's from
0.28. 166
Yeah,
minus 50 is a
what
PaO2
is that over pi and all that stuff? Yeah.
116 millimeters of mercury. So I give a patient 2 liters of oxygen. My PO2 isn't 80 to 100, normally at sea level. It's 116. I've just manipulated my alveolar environment so that my PO2 is higher. So when you see patients on 2 liters a minute, what are some reasons why they would be on oxygen in the first place?
If their stats are low.
Saturation's low, alveolar collapse, atelectasis, pneumonia, any trauma, anything that causes enough alveoli to be affected that the PO2 is low, we therapeutically give oxygen to raise the PO2 and improve the saturation.
Yeah.
So we have to be careful not to give them too much, because that causes damage. But so if this is 116 in here, and then it goes through gaseous exchange, and all the alveoli end up with a PO2 of 76. So now I've got a P big A O2 of 116, and I've got a P little a of 76. So my big A is 116, my little a is 76. There's an assessment that we do, so I'm jumping into patient assessment. There's an assessment called an AA gradient. A big A to little a gradient. And an AA gradient is simply the alveolar oxygen level subtract the arterial oxygen level. 116 minus 76 is what?
44 plus 16.
Right? If we understand that whatever's in here should get to here and reach equilibrium, then the AA gradient should be 0. But like all things, we accept a range, basically less than 15. So if you figure that your PaO2 at sea level is 80 to 100, so 80 or 100 down to 80 is a difference of 20 millimeters of mercury. That's why the AA gradient, as long as it's less than a 15 difference, then it's within normal ranges. 80 to 100 is within the AA gradient of less than 15. And so sometimes a physician will do a blood gas and they'll say, Truman, what's the AA gradient? Well, it's just the calculated big A subtract the little a, and you get the difference between how much is diffusing across the alveolar capillary membrane. And it should be less than 15 to 20. If it's greater than, in the other example I gave you a PO2 of 424, and what if my PO2 is only 76? But I'm giving them 100%, or I'm giving them 80%, but what diffuses across there is only 76. Now, and where do I get this number, by the way? How do I measure the P little AO2? From an ABG. Yep, I draw blood, I stick it in the machine, and I measure it directly. How do I get the P big AO2? I have to calculate it. Calculate the big AO2. I directly measure the arterial O2. So what if I've calculated at 80% my big A, and I measure it, the P little a of 76. What's the AA gradient? 424 minus 76. What is it?
348.
That's a wide AA gradient. And that tells me something. It tells me the pressure difference between what's available here and what got to here. The AA gradient. The AA gradient is an important assessment to help us to understand how much diffusion was affected. Because what should it be? If the alveoli is 424, what should the arterial system be? 424. It should reach equilibrium. If it doesn't, that means there's water in here, there's scarring, there's atelectasis, all the problems associated with the deficiency in gas exchange. Make sense? So it's a pretty powerful number to be able to tell and understand what's in the alveoli, and then we measure what gets in the arterial system. And that difference is an extraordinarily powerful number. Should be less than 20. If it's wider than 20, if the difference is wider than 20, then we have to look for pulmonary disease.
Wait, so the gradient has to be less than 20? Okay.
And the reason it's less than 20 is because it should read, whatever's in here should get to there. And if it's not, there's a reason why. And that's where we come in to be investigators. Go ahead, Jerry.
So with that example where it was 40, we would be looking for some arterial reason as to why they're not.
Yep,
Okay.
we'd look at a chest x-ray, we'd ask them questions. Have you developed a cough? Is there anything, are you allergic to anything? Have you been short of breath? Trying to find a reason for the difference.
Okay.
So all of us have a PO2 of around 72 right now. If I were to do blood gases on everyone, your PO2 should be 72. If it's less than that, we'd have to find out reasons why. We'd have to explain it in a way that was caused by pulmonary insufficiency. Or, in addition to gas exchange going in and out, you have to think about the blood going round and round from your heart. So it's usually heart and lungs that causes these differences. So the alveolar gas equation, very important, helps us to determine what's in the alveoli, so that it can diffuse across the capillary membrane into the arterial system. We can measure the arterial system. We get an approximation with the saturation. We'll talk more about saturation. But the PO2 is what's there and what should diffuse across the alveolar capillary membrane. So mixed venous blood that's just gone through gaseous exchange and delivered its oxygen to the tissues to create energy comes back with a PO2 of 40. So why isn't that 0? We don't use all the oxygen, we send some of it back. We send almost 75% of it back.
Yeah. Of the oxygen?
It's another way we're over-engineered.
Stays there
The good
just in
Lord,
case.
he or she was pretty damn smart to figure it out. So we send 75% of the oxygen back.
So you stop breathing for a little bit, and hope you can still survive.
You're
for a
still
little while.
okay for about 4 minutes. CO2 is produced by cellular metabolism. If we create more energy, in creating ATP, we create more CO2. And CO2 then is a reflection of how well we're metabolizing sugars and creating energy. So what's in here is higher than what's in here, so we give up CO2 and exhale that to the environment. But typically speaking, if you look at the diagram on page 190, we set up a gradient. There's a particular partial pressure before the vessel gets to the alveoli. There's a particular environment within the alveoli, and then that leaves us with what goes back to, back to the heart, really. So this blood goes back to, here's the lungs, heart's in the middle, right? Trachea, aorta. So what comes back to the right side of the heart sends blood to the lungs. And then what comes back into the left atrium is really just an average. So this PO2 is an average of all of the gas exchange that takes place in the right lung and the left lung. What comes back to the left atrium is an average. The PO2 is an average of all of that. But we're over-engineered. We're over-engineered in the number of alveoli. We're over-engineered in the way that we send blood to all those alveoli, and then how it comes back to the left atrium is really just an average of all of the gas exchange that's taken place through 300 million alveoli. We only use 25% of the oxygen in gaseous exchange from the right side of the heart. When that blood comes back to the right side of the heart, there's still 75% of the oxygen still there. So we're over-engineered, our tissues are over-engineered to use what little it requires, but we still have to, to keep the process going, we still have to breathe in and out. Our heart still has to beat to push blood around, and it's an amazing process. You stop to think about any one part of it, let alone the chemical processes of gaseous exchange. So, in about a quarter of the transit time, on 190 it says that the transit time is about 0.75 seconds. So the time that blood comes in contact with the alveolus to the time it leaves the alveolus, that's about 0.75 seconds. Under normal conditions, gaseous equilibrium occurs in 0.25 seconds. So less than a third of the transit time, equilibrium's already occurred. And then the rest of that time is just kind of equilibrating. But in normal circumstances, oxygen and carbon dioxide is transferred across the alveolar capillary membrane in about a third of the time that it has available for gaseous exchange. Certain diseases, however, over on 191, the transit time doesn't usually increase. It's based on how the heart's pumping blood. So in diseases where the alveoli are collapsed, where there's obliteration of the single-cell thick structures, when you in emphysema, instead of having 5 or 10 alveoli at the distal terminal bronchioles, you've only got 1. I mean, surface area is greatly reduced. It may take more than 0.25 seconds to reach equilibrium. It might take 0.5, it might take the whole 0.75. So again, we were over-engineered in the amount of time that we have available for gaseous exchange. Certain diseases increase the time it takes to equilibrate. Alveolar collapse will change the way it equilibrates. So the diffusion of gas is dependent upon a couple different things. It's dependent upon certainly the flow of blood past the alveolar capillary membrane, but three specific variables. So when you think about Fick's law and gaseous exchange, you don't have to plug in figures. You just think about the law and the relationship it has with factors that influence gaseous exchange. Did you have a question, Jeremy? Okay. So the factors include the area. So if we reduce the surface area, then it reduces gas exchange. If we reduce the partial pressures, so by manipulating the alveolar environment, if we reduce partial pressures, like going up in altitude, then we reduce the gas exchange. Or if we reduce or make the thickness of the tissue more pronounced. If there's fibrosis and scarring, it's another layer that oxygen has to diffuse against. So Fick's law sets up three different specific ways that we can reduce gas exchange: by reducing partial pressure, by reducing surface area, or increasing the thickness of the tissue. So when you think about Fick's, you think of surface area, partial pressure, and thickness of the tissue. It's relative to how we diffuse oxygen and carbon dioxide. If you think about Henry's law, Henry looks at the solubility coefficients, and on the bottom of page 193, it illustrates that the solubility of CO2 is 24 times that of oxygen. So at this point right here, we've got a partial pressure difference of 6 millimeters of mercury, right? For CO2. For oxygen, we've got a partial pressure difference of 60 millimeters of mercury. But CO2, based on its solubility coefficient, diffuses 25 times faster. So that tells me that even with a partial pressure of 6, CO2 still diffuses faster than oxygen does, 24 times faster than oxygen does, based upon its solubility. Graham's law looks at the gram molecular weight. Oxygen is a molecule that occurs in pairs of 16. So 2 oxygen molecules is 32 grams, right? So O2, 16 plus 16 is 32. So oxygen is 32. Carbon dioxide is CO2. 1 carbon of 12 and 32 would be 44. Is that right? Yeah. So if you look in terms of Graham's law, then, Graham's law is relative to the gram molecular weight of the gas. Well, we're only concerned with oxygen, carbon dioxide, and based upon the molecular weight, carbon dioxide diffuses 20 times faster than oxygen does because it's heavier. It's a heavier molecule. So what you remember with the laws, Jimmy, is that Graham's law is based on the gram molecular weight. CO2 is 20 times more. It diffuses 20 times faster than oxygen because it's heavier. And it diffuses 24 times faster because of its solubility. That's all you remember for Graham and Henry's law. And what was Dalton's law?
Partial pressure.
Law of partial pressure. And what was Fick's law? 3 things. The surface area, thickness of the tissue, partial pressure. That's what you remember about the laws. That's what's important for us. Yeah.
Okay.
Yeah, we're not going to put numbers in there or make you memorize.
Thickness,
It's
partial
relative
pressure,
to
and
what
what?
we need to know.
And area.
So remember the specific factors that are associated with these laws. They're not too tough.
So with Fick's law, is that what technically affects when people have like sickle cell anemia?
Yes, it could,
Okay.
because the partial pressure changes because of the structure of sickle cell. Or it could be illustrated in fibrosis or scarring. So if there's an extra layer of tissue then it takes longer to diffuse across the alveolar capillary membrane if it's thick tissue. Because we have to diffuse across 9 layers. If you've got 9 layers plus a scarred layer of fibrosis, then we wouldn't expect diffusion to be as much. And we measure that. Do any of you know how we measure the thickness of the tissue? Not by a scanning microscope.
Oh, man, I forgot.
Have we talked about we have in assessment, DLCO. How fast does carbon monoxide diffuse across the alveolar capillary membrane?
Really?
250 times faster than oxygen. And if you have oxygen and carbon dioxide near a person, what is the hemoglobin preferentially attached to? Carbon monoxide. So it's 250 times more soluble than is oxygen in the hemoglobin. So the point is that you can measure how fast the DLCO changes in a PFT, and it gives you the integrity of the membrane, how thick the membrane is. So the DLCO is an example of a test that we do to look at the thickness of a membrane in Fick's law. The thicker the membrane, what happens to diffusion? It goes down. Okay? So these are all pretty relative to the way we understand gaseous exchange of oxygen and carbon dioxide. Okay. Last part of the chapter talks about the difference between, let me talk about the clinical application of Fick's law. And if you'll permit me, I think it's important the way they explain it here. In those three components, the area, the partial pressure, and the thickness. So clinically, Fick's law applies to the following general statements. The area component of the law is verified in that a decreased alveolar surface area, like in emphysema, or alveolar collapse, or decreases the ability of oxygen to enter the capillary blood. The partial pressure portion of the law is confirmed in that the decreased alveolar pressure, like high altitudes, and we illustrated that. At high altitudes, the PO2 is 30. At sea level, the PO2 is 80 to 100. So just by going up in altitude, the partial pressure drops, and that affects Fick's law. The thickness factors confirm that in an increased alveolar tissue thickness caused by fibrosis or edema reduces the movement of oxygen across the alveolar capillary membrane. It increases the number of cellular layers that oxygen has to diffuse through. So what's interesting is that in discussing Fick's law is that oxygen can be both. It can affect the diffusion of gas across the alveolar capillary membrane. The way they describe that is in the concept of perfusion-limited and diffusion-limited gas. So in perfusion-limited substance, look at the bottom of page 196. Diffusion-limited, they use a gas of nitrous oxide. Anybody ever used nitrous oxide? You go to the dentist, they put laughing gas. They put laughing gas on your nose, and you breathe it in and out. But look at how nitrous oxide diffuses across the alveolar capillary membrane. It doesn't take it a third of the transit time. It does it in about a tenth of the transit time. Look at the diagram. So nitrous oxide is equilibrated very, very quickly. And so here you've got a partial pressure in the alveoli from breathing in nitrous of 10 millimeters of mercury. Remember, torr is synonymous with millimeters of mercury. So the dentist turns on the nitrous oxide, he puts it on your nose, and you breathe that in and out with a partial pressure of 10 millimeters of mercury. It diffuses across the alveolar capillary membrane within 0.1 seconds and reaches equilibrium. So once it reaches equilibrium, diffusion stops. So the only way to get more nitrous oxide into the blood, so next time you go to the dentist, you'll have to do this. Well, or maybe I should ask you, what's the way to get more if diffusion stops in a tenth of the transit time across the alveolar capillary membrane, how do you get more nitrous oxide into your blood?
Turn it up.
Oxygen?
Turn what up?
The nitrous.
not the nitrous.
Oxygen.
Nitrous is,
Flow.
not the flow. The only way to get more nitrous oxide is to move more blood past the alveoli. So when you go to the dentist next time, run around the building 3 or 4 times. Get your heart rate up, and then plop down in the chair and put the nitrous oxide. So you've got more. So that's an example. That's an example of a perfusion limited gas. Nitrous oxide is a perfusion limited gas. You can't get any more than what's there unless you move more blood past the alveolar surface.
So like sometimes nitrous oxide doesn't really affect me.
Yeah, because it reaches its equilibrium and it doesn't, it doesn't ever get higher.
Oh.
So the way you make it higher is you run around the building 4 or 5 times, make sure your heart rate's 100, 120,
Do some jumping.
and then you plop down in the chair and you say, okay, give it to me. Turn it up, Doc.
The more nervous you are, the more.
Yes. The more your heart rate is pumping, the more gas you get.
That's probably why it affects my brother so badly. He hates the dentist.
Hates the dentist, probably anxious a little bit. His heart rate's going up, so he gets a little more gas. Because it's a perfusion limited substance. A perfusion limited substance is dependent upon the blood flow that goes past the alveolus. Okay, so nitrous oxide is an example of a perfusion limited substance. A gas that reaches equilibrium quickly. The only way to get more, once equilibrium occurs in oxygen, no more diffusion occurs, right? The only way to get more oxygen is to hyperventilate so that the CO2 goes down. That allows more oxygen, or to move more blood past the alveoli.
So when they ask if they want or if you want them to turn it up, doesn't really matter.
Doesn't matter. What they're doing is they're just turning up the flow. The partial pressure is the same. So there's a therapeutic amount, and they've determined what it is, and they don't usually go much up past that.
That's funny.
So it's a perfusion limited substance. Nitrous oxide is an example. Because it reaches equilibrium so quickly, no more diffusion occurs after equilibrium has occurred. So it's a perfusion limited gas. The only way you can get more is to increase the flow past that, past the alveoli. So let's see. So a diffusion limited gas, they use carbon monoxide as an example. Carbon monoxide is because it takes, in this case, you've got 10 millimeters of mercury in the alveoli, and once it reaches its transit time of 0.75 seconds, there's only 1 millimeter of mercury in the arterial blood. So it never reaches equilibrium. A diffusion limited gas is an example of in this case, carbon monoxide. It becomes evidence as to the integrity of that membrane. Because it never reaches equilibrium, it only diffuses as well as the membrane allows the gas to come through. Okay, so a diffusion limited gas is an example as an example of carbon monoxide in the way that it travels across the alveolar capillary membrane. So the partial pressure is 10 millimeters in the alveolus. Even after 0.75 seconds, the partial pressure hasn't been equal. You've only got a partial pressure of 10. The only way to get more carbon monoxide is to improve the integrity of that membrane, to improve diffusion across the alveolar capillary membrane. So the lung's ability to diffuse gas is called the diffusion capacity of carbon monoxide. A DLCO test that measures the amount of carbon monoxide that moves across the alveolar capillary membrane into the blood. The test measures the effectiveness of the alveolar capillary membrane itself. So if there's scarring, if there's water, if there are things that limit diffusion, it's a function of the integrity of that membrane. Okay? So you remember diffusion limited as the integrity of the membrane, and an example is carbon monoxide. Perfusion limited is where a gas reaches equilibrium. The only way to get more gas across the alveolar capillary membrane is to increase the blood flow past it, the perfusion. past the alveoli. Okay. Well, oxygen can behave both ways. In normal circumstances, oxygen's a perfusion-limited gas because it reaches equilibrium not in 0.1 second, but in 0.25 seconds. And then equilibrium's occurred and gas exchange stops. But in disease states, oxygen behaves like a diffusion-limited gas because even though you have 0.75 seconds to move blood across the alveolar surface, it may not reach equilibrium because of collapse, because of scarring, because of fluid, because of interstitial space, whatever. So oxygen behaves both ways, as a perfusion-limited gas normally and as a diffusion-limited gas in disease states. Okay? So they use that example to try to illustrate how oxygen behaves both ways. Oxygen's a good thing, we like it. It improves cellular function, it creates energy and ATP. It's good at a physiologic level, but it's bad at a higher level, over 100. So we have to watch and be careful that PO2s don't often rise above 100. When have you seen PO2s over 100? Did you have an example?
In the hospital.
Sometimes in the hospital we give oxygen and PO2s go over 100.
So would you have to turn it down then, or is there
You
different
should.
sizes
I mean, we loosely monitor that with saturation. But there are conditions where it's okay to have PO2s above 100. An example would be a heart attack. So we're trying to oxygenate and vascularize the vessels in the heart to make sure that the heart has as much oxygen as it needs. So PO2s for heart attack patients are okay over 100. Most other cases, most other pathologies, we try to limit it at about 100. Recognizing that here at this elevation, 70 is okay. You know, and 60 is probably okay. You know, the way we look at oxygen saturation in terms of always wanting to be 90% saturated, 60 millimeters of mercury is okay. It's low, but it's okay. Okay. That's going to conclude that chapter. What do you think? Where do we need to refocus?